So good morning, everyone, and welcome to the Want to Know More About Cancer Removing Barriers and Improving Outcomes session. This is a free webinar that will be delivered by myself, Louise Cresswell, from Public Health Leeds City Council, and my colleagues Darren Meade and Megan Arundel from Leeds Cancer Awareness Service. It's Friday the 11th of February, and the time is 10:36. So we aim for this session to be finished by midday at the latest. So I introduced ourselves very briefly there, but just to give you a little bit more detail about ourselves, who we are and what we do, I'll just hand you over to both my co-presenters this morning, Darren and Megan, to introduce themselves.
Yeah, I'll go first then, Megan, I think. Good morning, everyone. Thanks for coming along. Lovely morning that it is. So yeah, my name's Darren Meade, and I've been with the Leeds Cancer Awareness Project now for 5 years. I'll explain a little bit more about who we are and what we do later on, but I'm one of the project coordinators along with Megan, who will introduce herself now.
Good morning, everybody. I'm Megan Arundel, and I'm the other coordinator for Leeds Cancer Awareness Project. And I joined the team in October 2019, I think, so just before we got hit by the pandemic.
Brilliant. Thank you both. And as I said, I'm Louise Cresswell. I work in Public Health, Leeds City Council. I'm a health improvement principal with a role specifically around cancer. Within the Leeds Cancer Programme in the city, I take a lead for the Leeds Cancer Prevention, Awareness and Increasing Screening Uptake workstream. So that's us. In terms of an overview of this morning's session, so I'll just run through this just to make sure that you're all in the right session this morning. So I think you'll know from having applied for this this session today, we are aiming for session participants to come away with a greater knowledge and understanding of the following points. So firstly, cancer and health inequality. So we're going to go into a little bit of detail today around cancer data, around cancer and health inequalities, so that you can understand some of those trends and what we're seeing in Leeds. And we're also going to talk a little bit about, in terms of cancer health and health inequalities, what our strategic drivers are, both from a national level and locally. We'll also look at the barriers to cancer screening awareness. So what is it that's preventing people from accessing cancer screening services, holding people back from doing so in Leeds? We'll also talk about programmes in Leeds to narrow the gap in cancer outcomes. So we take a real partnership and systems approach in Leeds, and you'll see when we cover that in a bit more detail that, you know, we've got real partnership buy-in to this agenda and real passion behind that as well, which is really supporting us to move forward with addressing cancer and health inequalities and barriers to cancer screening, uptake and awareness. And then we'll come at the end, towards the end of the session, to have a real focus on the community approach to increasing awareness and screening uptake. So that's when my colleagues Darren and Megan will talk a little bit more specifically about the service that they work for, so the Leeds Cancer Awareness Service. So that's a very brief overview of what we'll cover this morning. So I wanted to start by talking to you a little bit about cancer and health inequalities and what the data tells us. So the data you've got on your screen in front of you is basically for the 3 national cancer screening programs. So there's a national cancer screening program for bowel, one for breast and one for cervical. Now, screening is so important in catching cancer in its earliest stages or when there's early signs of cancer. And we know that the earlier that cancer is diagnosed, the better the outcomes. So that's why screening is so important. And that's why we as a city and as partners working within cancer are very interested in these screening uptake rates and what they're telling us. So you can see from that table there, what we've included is the national targets that have been set for each of those screening programs. And underneath that figure for each of the programmes, I've included the most recent data that we have access to for local performance. So you can see, looking at our local performance for bowel, that we're really over exceeding the national target, which is brilliant. And interestingly, throughout COVID, that figure's continued to rise, which is really positive. As you can see for breast and cervical, however, we do sit significantly below national target for both of those, looking at our latest performance data. And that's why, you know, we do have the programs that we have in place in Leeds and the various different steering groups and work streams to really address that. But I think what we really wanted to highlight through this data, most importantly, is the IMD1 figures, which are presented underneath that data. So IMD stands for Index of Multiple Deprivation, and IMD1 is basically our most deprived areas in Leeds. So if you look at those figures for all three of the national screening programmes, you can see that screening uptake is significantly below our sort of performance in Leeds as a whole, and again much lower than national targets. So we recognise that and recognise the importance of addressing that. In addition to that, we also know that premature mortality, so that's deaths of those under 75, so cancer premature mortality, sorry, is higher in areas of higher deprivation. So basically, people are dying younger from cancer in areas of highest deprivation. So you can see those real health inequalities there. I've talked about areas of highest deprivation there. We also know that screening uptake is lower in specific groups and communities. So Darren will pick up later a bit more detail about what those specific who those specific groups and communities are. But again, in terms of our work in the city, we have a real focus around ensuring equality and driving towards that equality for A, the areas of deprivation, and B, those specific groups and communities. In addition to that data I've just presented, I'm sure you will be all aware, this isn't just specific to cancer, but the impact of COVID across the health system in general and on health and healthcare. Obviously, it has been huge, and I suppose the risk for us in terms of those health inequalities is that the cancer health inequalities could be exacerbated through the impact of COVID. So again, that's, I suppose, all of that put together really is our evidence for taking that really targeted approach in Leeds, and we continue to do so, and are going further and faster in light of the impact of COVID to work together to address that. So I covered the data there in relation to cancer and health inequalities. I suppose what's also really helpful to cover is the national and local strategic drivers that are really, I suppose, supporting us in taking that real targeted focus around cancer and health inequalities. So just to give you a quick overview of some of those drivers. So at a more national level, we've got the NHS long-term plan ambition and the NHS England approach to health inequality. So both of those have a target of 75% of cancers being diagnosed in the early stages by 2028. I've already covered with yourselves why it's so important that cancers are sort of diagnosed in the earlier stages in terms of you know, the improved outcomes if cancers are caught earlier. We've also, and I suppose the NHS long-term plan and that drive towards health inequalities through NHS England have been qualified for primary care at a local level through various different contracts and specifications, which I've just outlined briefly there, but they focus specifically around cancer and early diagnosis. So primary care does have a drive towards that through its contracts as well. We've also got the Leeds Health and Wellbeing Strategy at a local level, with that focus and that vision where people who are the poorest will improve their health the fastest. And then we also know that cancer premature mortality, or as I mentioned earlier, where people are dying under the age of 75 from cancer, is one of the 3 main causes of the gap in life expectancy. So the Leeds Joint Strategic Assessment from 2021 states that although there's a downward trend for cancer mortality overall, which is obviously very positive, what we need to be aware of is that Leeds rates are still remain significantly above regional and national averages, and that deprivation gap is not closing. So again, added to the data I provided earlier, that again adds to that real drive towards addressing cancer and health inequalities.
So someone's popped in the chat box, could it be that people are not aware of the importance of the screening?
Yeah. Absolutely.
The answer would be absolutely, wouldn't it?
Yeah. And we will go on where Darren's picking up now. I'm handing over to Darren, and that's over the next few slides. That's absolutely the areas that Darren's going to be picking up with yourselves.
Yeah, if we could ask you that as you sit here, what comes to mind? Why? I mean, you know, what a great thing we've got cancer screening. You would think we would be queuing around the block, wouldn't you, to get it? We'd have 100%. We'd have people complaining they can't be screened more regularly, and it's not the case. So as you sit there now, as clever professional people with some insight into how people go on, why do you think that is? We'd love to hear.
I've got fear.
Yep, without a doubt. I think that might be the next slide.
Some people find it quite intimidating and scary.
Absolutely.
There are barriers to cervical screening for trans and non-binary people who either don't get sent cervical screening letters due to admin errors or find the environment or approach to be traumatic.
Yep, great point as well. It really is. But I think that's clearly we're going language barriers as well, which is something it's a good crowd today. It's a good crowd. You know already. So I'll just get into it then. And certainly this is things that Megan and myself have found through his work and focus groups that we've carried out in the past around various cancers and screening and things. So the first one really is, as just got mentioned, is that fear. You know, cancer, when Megan and myself are out and about in the communities and talking to members of the public, one thing we'll often hear back from certainly some of this, we call them more vintage rather than old, but more vintage members of Leeds. I like that as I'm heading that way myself. They will turn to Megan and myself and they will say, "Oh, I'd rather not know, love. I'd rather not know." And, you know, with any other type of health condition, to say that, if you were to say that about, say, gangrene or say that about cataracts, it would immediately sound nonsensical. It would be like, well, you're going to go blind if you don't get those cataracts sorted out. To say you'd rather not know about them would seem nonsensical. And yet with cancer, it creates such sort of it's got such a history, and it's such an emotive subject, and it's so frightening for people because of the point just below there, that you've got cancer, that's you done, someone's got cancer. And, you know, going back in time, before we had some of the fantastic sort of medical and clinical interventions and treatment packages that we have now, that could well be the case. You know, and it was a type of thing almost you get primed to it from growing up, you know, parents talking about it in hushed tones, you know, not wanting to talk about it in front of the children and things. And so, yeah, that's one of the things. If you don't know, people are often very anecdotal with Megan and myself, saying, well, look at my sister-in-law. She was absolutely fine. She went for a breast screening. They found breast cancer. She died 6 weeks later, as if in some way, shape or form that going for the screening is what caused her to pass away, rather than the fact that they picked up on a late stage 4 or something like that. So that's definitely an issue, the fear. And, you know, none of us here want a cancer diagnosis. Of course we don't. And one of the easiest ways not to get one is not to go and get diagnosed. So just don't go. And that whole putting his head in the sand about it, that whole putting it off, you know, people are too busy for it and things. And ultimately, it's that fear of what we're going to find out, isn't it? It's one thing not going, it's another thing having gone and then waiting on test results. You're in a totally different mindset, aren't you, waiting for test results? So lots of people, through the fear of what they might find out, especially if they're living a life where they think, oh, well, you know, if you smoke and things, you'll do anything to swerve that. So that's certainly one of the ones. The next point there, scared about attending first screening. We fear that unknown, don't we? You rarely hear that somebody's screening experience has been absolutely fine. It's like going to a bad restaurant, people would tell everyone. So you kind of hear these stories, almost for cervical, certainly, with it starting younger than the other screenings, almost playground stories and anecdotal stories of what it's like, and talk of big. Yeah, I've just seen that comment come up there. Yeah, it can be. Most things like this, most of these procedures can be a little uncomfortable, can't they? The bowel screening's just a bit of a faff, shall we say, because it happens externally. But certainly cervicals, I've heard, are uncomfortable, and the breast screening can be uncomfortable. And that can be enough to put somebody off. A bad experience, a backward tilting cervix that wasn't picked up on in somebody's first cervical screening, someone can say they found it really quite painful, and that will just put them off going back again. And, you know, we've put sort of the social consequences there, which I'll get into later. That thing of being diagnosed, everything unraveling, your normal day-to-day worries and concerns, suddenly just blown out of all proportion. You've just come away, you've been told that you've got a cancer. You don't understand it might be an early stage 1 breast cancer, which can be quite successfully treated. About 99% of stage 1 breast cancers are successfully treated. But people don't walk away from the doctors hearing that. They just think, I've just been told I've got cancer. So there's a whole thing about putting his head in the sand about that. There's also a lot of myths around. Some people get so overwhelmed. If you've ever looked at the Daily Mail, if you've ever Googled the Daily Mail's headlines and stories it's run for cancer, it's madness how much people get told in that particular tabloid what causes cancer. Left-handedness, cars, Facebook, soup, having children, not having children. So people end up just getting almost overwhelmed and have this idea of, well, what's the point? What's the point in even trying to kind of avoid it? You know, if it happens, it happens, and we'll just roll along like that. There's also a whole culture as well around men not going to the doctors anyway, but we can get into that at a later date. And not everyone has that access to reliable cancer information. You know, we know in light of COVID and everything, a lot of people get their information at the moment through their social media, and they don't go away and they don't look into things. Yes, I've just seen the comment there from which we promote later on in reliable websites, the kind of behind the headlines things that will explain. If you remember popcorn lung, about vaping, cropped up a little while ago, this condition called popcorn lung. It sounds horrendous, doesn't it? Popcorn lung. You picture the inside of your lungs sort of all bubbling up and things. It wasn't the case at all. What was happening was people that worked in the factories that were producing the chemicals that flavour the vape liquids were the one that was flavoured like buttered popcorn. If people were exposed to that in high doses, they were developing a higher incidence of developing certain cancers. But that doesn't grab the headlines, does it? And that's what the papers are about, you know. So yeah, another thing is stigma. Megan and myself come across this in can be cultural, depending on what cultures people are brought up in. But the idea that and this, I'll touch on it again in a little while, sort of religious implications, all the karmic belief in karma and things, belief systems. You know, what have you done in your life to kind of to deserve cancer? So this can be a thing. People are so frightened of the stigma then of having cancer that they will try and avoid it. People don't talk about it. You know, it's the other C word. And we're making huge leaps and bounds with mental health and people starting to talk about their mental health and understanding that opening up and the Andy's men's clubs and things, all the work done there. And we're really hoping that people do the same about cancer and screening and talk to one another about it and put each other at ease, you know, and offer to go with friends if someone's got an issue, not wanting to go for the cervical and things, not just keeping it under this kind of under the table thing. And people are embarrassed, you know. People are embarrassed about going along. People don't want to. It's dependent on what's being done, depending on what screening's taking place. It's a little intimate. They don't want to have that done. When you think about any movie you've seen, when somebody, it's normally a comedy. It's normally a comedy, and it's normally a man going for a prostate. He's got a problem with his prostate. He's having a prostate check. And 99 times, I don't think I've ever seen a movie where someone's had a PSA test, blood test to check their prostate, because it's not funny. It'll be somebody bent over in a hospital gown with some doctor, putting a finger up the bum, because that's comedic. And that's enough sometimes to put people off. Genuinely, it's enough. We have conversations with guys all the time that will just say they're not having anyone doing that. They're not having someone push a finger up the bum. And they don't realise that it's a blood test at first. So that's part of the message Megan and myself put out. And moving on, you touched on it earlier there, Louise, with the whole COVID situation. But even prior to that, once somebody's decided to get in touch with their GP, once they've got maybe a sign or symptom that they're concerned about, or they've had the letter through inviting them to phone up and make an appointment for a cervical, they're struggling. And people are struggling to get through to their GPs. Megan and myself do a lot of work with GPs across the city, and sometimes we get frustrated by ringing up and the phone just ringing out and not having the opportunity to leave a voicemail and actually contact the GP. Or you can't see your usual doctor. You turn up on the day, you're concerned about something that you might find embarrassing. It may be something intimate, and it's not the person you were expecting to talk to. Or you just don't have much faith in your GP. You don't think they're very good, which we hear a lot. Well, my GP's rubbish, or people are anecdotal about that. Or you're embarrassed, as we said earlier, you're embarrassed to talk about your symptoms. Something's a little uncomfortable. You're not quite, it's awkward, isn't it? It's awkward, and you don't want a cancer diagnosis anyway, and you'd rather just put it off. So this all starts layering up a little bit, and practical issues of getting there, which I'll kind of touch on again in a little while. But it can be difficult for some people to actually get there. So you've got an embarrassing symptom, embarrassing to you. You've struggled to phone up. You're going to struggle with getting to the surgery, and you're nervous about what this potentially might be. So all these things start building up a little in your head, and it's the easiest thing in the world just to swerve in it. One thing psychologically people will do is, I tried phoning up. I got my letter for my cervical. I tried phoning up, but I couldn't get through. And then you've kind of done your bit. You're kind of offsetting the responsibility there, because I tried doing what I could, but I couldn't get through. And then that letter gets forgotten about. And of course, the luxury of being able to phone people up and chase them up for certain screenings is just that. It's a luxury. And some surgeries are able to do it more than others. But certainly something like the bowel screening kit, when that gets sent out, for lots of people that arrives, if they don't do it there and then, there's no follow-up. It's just put to one side, and they miss out on that. So as I mentioned earlier, sort of religion and cultural barriers. There was one thing that I think was a study in Manchester going back a little while ago, where some Asian women were not going for chemo treatment once they had been diagnosed, once they'd actually discovered the cancer, for fear of losing their hair, because then that would then put a message out to the wider community and things that they had cancer. And there was this stigma there about the idea that everything comes from God, both good and bad. So this idea that somehow in your private life you'd been living a life that deserved cancer. So for fear of bringing sort of the shame of that onto their families, they were avoiding going for their chemo treatment and losing their hair. So literally, losing family members through this idea that somehow cancer is you're to blame for your own circumstance, and that has to change. But going up against that's very difficult. I mean, Megan, you were sort of doing a talk yesterday to some Asian ladies, were you, down at the Bahama, and just getting out there and getting people to sort of realise that cancer isn't good or bad. It's not cruel. It doesn't think. It's a very natural process that occurs to people. It can be, horrendous for people to live through, but it isn't this idea that it somehow picks and chooses. That fatalistic thing of, what will be, if your name's in that book, you're going to get cancer, whether or not you live a healthy lifestyle or not. That's certainly a thing that some people make their way through life with. Certain influences within the community. We've just seen this with COVID as well. I did a talk a couple of years ago to a group of women, one of whom had been brought up in the family. It was very much a case of the breast screening causes cancer, and also looking, if you push too hard, looking for lumps when you're self-checking, then you can cause cancer by pushing too hard like this. So that absolutely believed that, and that whole family, the whole family from which the lady came from, absolutely believed that. And these things get passed on, don't they? Passed down, if they get talked about at all, which goes back to what we were saying earlier about cancer kind of being hushed up. But if families are talking about it and it's the wrong information, then we've got a real problem there, haven't we? Language barriers can certainly be an issue. All the letters that get sent out tend to get sent out in English, and they can be quite, clinical. Certainly the bowel screening kits that come out are for everybody of all reading levels. So if you don't read English very well, if you come from a culture where it's very much spoken word information, and this comes through your door and you're not sure what you're looking at, then the easiest thing in the world is for that just to put to one side. And just a final one there, which ties into another thing we'll cover in a minute, which is sort of trauma. Childhood trauma is female genital mutilation, and somebody not going along and presenting to their GPs, to their surgery for cervical screenings because of that. Also, controlling partners and things. Some partners just don't want it, don't want you to go along, not having it, not who's carrying out this, who's carrying out this procedure. No, you can stay here, and how do you get around that? How do you know that that's the reason someone hasn't come along and been screened? So I mentioned it there just a little with the female genital mutilation, but trauma can be a big one. And when Megan and myself are doing talks for people, we kind of stress this in wanting to be caring for somebody. We can sometimes be a little self-righteous. Someone may say, because you'll all have friends, family and friends, that if you ask them, they'll say, I haven't been for my screening, or I didn't do my screening. And we can be a bit like, what? You've got to go. It's really important. And a little self-righteous sometimes. We don't mean to be, but we are a little, because we want them to go, and we want them to take care of themselves. But we may not know that person's been through, some horrific childhood trauma. The idea of being in a room, certainly for cervical, in that situation, in a locked room, in quite a vulnerable position, might be a massive trigger for somebody's anxiety because of what they've experienced. We were talking to a nurse in a practice only the other day on a different training course that said, it crops up all the time for her. People will talk, and we always encourage people to ask for longer appointments, explain prior if they feel comfortable. You can take a friend along, which people don't know, so this is kind of information that we always put out there. People can have a friend or a partner. One woman we spoke to said that for her first screening, a cervical, she would have absolutely loved to have had a husband there, and I had no idea that can totally be a thing. I know COVID rules have been a little bit difficult for access to surgeries, but Boris informs us that that's all going away now. So that's something that could open up again, and people don't realise that. As I said earlier, a bad screening experience can put someone off, just like a bad restaurant experience or a bad dentist. Childhood dentist's experience can stop people going for pretty much their adult lifetime. And this whole thing that it causes cancer, and we're riddled at the moment with misinformation about all manner of health related things, aren't we? Just for the social health inequalities that Louise touched on, different areas have better and worse healthcare in different population groups. Some surgeries are absolutely struggling with huge numbers of patients and things, whereas some affluent areas, you know, not so much, and people can pay for private healthcare. And this is the other thing for screening, you know, there's a huge algorithm set up to work out what's the most cost effective for how many cancers that we're going to find in the time that we've got, for the numbers that we have, with the resources. You know this. I don't have to explain this to you. Well, of course, if you're rich, you can go get screened, you know, as often as you want. Pay for it. You can go along to private healthcare and you can get screened as often as you want. It's, you know, the money. Is it any surprise that rich people often live longer than poor people, you know, for all manner of reasons? I think I might be right here, Louise, the life expectancy between Hare Hills and Harewood is about 10 years longer if you live in Harewood in general than Hare Hills. And, you know, that's a what, 10-minute drive, 15-minute drive?
Yeah,
And,
I
and
always say for every mile, I think it is, that you drive from inner Leeds to outer Leeds, you gain a year in life expectancy, and it's just not acceptable, is it, in the day and age that we live in?
crazy numbers, and yet there it is, you know. So deprivation, it's one word, but it covers an awful lot of things, doesn't it? And it goes back to all manner of things, you know. Education when you're younger, family environment growing up, you know. Often if you grow up in a household where people smoke, you may just fall onto smoking yourself. If drinking's very much the norm, substance use, all manner of things. Just poor diet. I'm not going to go on and on about this because I'm sure you can all fill in the gaps on that as to why somebody who's living in a high area of deprivation may be living a lifestyle that's not as conducive to being fit and healthy and well as someone who's more affluent. So this slide here really is just to try to cover a lot of the groups here. Megan and myself are target groups for ourselves. We don't have men. One of our target groups is men. And like I say, it would be a whole different conversation about the cultural implications of why men don't go to the doctor. You know, oh, he's the strong silent type. What do we even mean? What do we even mean, the strong silent type, you know? Watch any movie and these blokes showing a blatant disregard for the well-being, you know? Vin Diesel riding on top of a car bonnet through New York. Come on, you'd think someone was a madman if they were doing that down Selby Road. But there's all these images pounded at men as to be fit and healthy and well and virile and confident and yada, yada, yada. And of course, that lends itself to not going to the doctors until things are more serious. We've talked to some old boys in the past, Megan and myself, and they proudly say, I've not seen a doctor in 20 years, lad. And they wear it like a badge of pride. And I guarantee is if I was to offer you a lift into town one day and as we climbed in the car said, oh, by the way, I've not had the car MOT'd in 20 years, you know, alarm bells would be ringing. You'd be eyeing that bus stop with renewed zeal. But it's this whole idea that if you go to the doctors, they might find something, or it's even seen as a slur. You know, someone may turn around and say, oh, you see him over there. Well, he's always up at doctors, he is. Well, maybe he is. You know, maybe this guy's always up at the doctors. Maybe he's got a load of health issues that he's trying to address. Maybe he's got problems, you know, but it's all that goes on. Anyway, it's a discussion. Sorry, I digress. That's a discussion for another day. But certainly people with disabilities, Megan and myself, our project targets people who have additional needs because they go straight under the radar. If you've got limited comprehension abilities and communication abilities, then you know, how do you know that if there's blood in your wee or there's blood in your poo when you go to the toilet that you need to go and tell somebody? Or if there's a lump and a bump? Or if you're a 22-year-old guy with you know, Down syndrome, then who's checking your testicles, your knackers? No one. Mum and dad aren't going near. You may have them checked at your annual health check review with your doctor, but there's every chance you won't. There's every chance that won't be included. That will come down to an individual practice. So the bowel screening as well for people with disabilities, the numbers are shocking for those returns, shocking for how many go back, because a lot of carers will sort of say, well, it's not really my job, you know, it's not really my role. And what happens is unless somebody takes the reins for that person and says, no, I'm going to help you with this, John, I'm going to help you get this kit solved, you know, and it means messing around with somebody's poo, then it just doesn't get sent back. just doesn't go back. Same with cervicals. People, you know, often parents, well-meaning, say, "Oh, well, they don't need that. They don't need this. Yeah, we don't want to put our child through this trauma. So they don't need to go." So that's often a thing that comes up. Or somebody, if they haven't had explained what's going to happen, is really frightened. Of course they are. An invasive procedure like a cervical screening, if you've got limited understanding of what's happening, or indeed for the mammogram, if somebody mentioned earlier that it's uncomfortable and downright painful at times. Well, if somebody with additional needs pulls away when they go along because it's starting to hurt and gets a bit panicked, then the staff have to see that as withdrawing their consent. This person is clearly they don't want us to continue with this procedure. So that makes for a very difficult situation. So of course, what we would ask people to do, carers to do, either professional or family carers, is to phone ahead, you know, talk somebody through what's going to happen. There are some fantastic, if any of you haven't seen them, fantastic resources that Change produce in partnership with Macmillan. Great big easy read booklets, lots of pictures, nice easy language, really good, really quality they are. And Megan and myself self-use them all the time, really, don't we, Megan, when we're out and about. They're also great for English as a second language or for people with low literacy levels, because it's just a nice big visual this is what's going to happen, this is why it's going to happen, talks people through the procedure. Great resources. Carers, very quickly, they put themselves on the back burner. Carers don't tend to look after themselves as well as they might. Certainly they don't go for their own screenings for a lot of the things we said earlier. Plus, you know, the logistics of it. So, well, I haven't got anyone to, you know, to care for the person I'm caring for at that time. But also they're really worried that what if they get a diagnosis? What if they then have to start around, you know, 5 rounds of chemo treatment? You know, it's almost like I'm too busy to have cancer. So they will put it off and they won't go along. We mentioned the deprivation. Different ethnicities have different approaches. Different culturally diverse groups have different views and approaches. We were talking to an interpreter from the Chinese Elders Association that we did a talk for a while ago, and she was saying that often if a child develops cancer in the first few years, something like a neuroblastoma, then family members and family friends will be asking the parents, well, can you think what you might have done while you were pregnant that's kind of caused this, you know, can you think what you've done, what's happened? And, you know, parents who are already worried sick, then riddled with this guilt for something that had absolutely nothing to do with the pregnancy, nothing at all. Homelessness, you can imagine, brings its own issues. I mean, where's the letter going? What are you doing? You live in a chaotic little hand-to-mouth life. You know, there may be substance use issues in there. You're all over the place. You know, you may not even be registered with a GP, which is the same for travelling communities as well. Where's that letter getting sent to? How are you going to get called in? Where's, you know, really difficult. Really difficult. So we mentioned the religious and cultural beliefs there as well. And people with mental health are another one of our target groups. Not your sort of, so we say, mild to moderate, but certainly some of your more sort of psychosis illnesses, your schizophrenia, your bipolar. You know, lives are really chaotic and all over the place when people are having, if they're not being managed, if they're not being managed through the medication effectively. So the idea that remembering that you've got to go along and do that cervical screening in 2 weeks' time, or you've got to go for that mammogram, can literally, you know, be the last thing on somebody's mind. So they're another target group. But if you start putting a few of these together with regards to barriers, you know, if you're a single parent and English is your second language and you've got 3 children of school age and you don't have any transport, and you get your letter through and the letter's in English and the letter's either asking you to ring up, or when you get your appointment it's at a time that isn't going to work because it's a school run and you've got no one there to step in, yeah, you're up against it, aren't you? You're up, and you don't really want to go anyway because you're worried you may have had a bad experience before and you don't want a cancer diagnosis. So all these things start compounding on and on and on. and you're really quite far away from getting through that door and getting checked out. Likewise, if you're a homeless person with mental health problems, you know, how do we get in there? Someone just commented there about the multiple reasons. Without a doubt, yeah, it's rarely just that one thing. You know, you could kind of link any of these up. You know, you're a homeless person with you know, with a disability. You could kind of shuffle these around as, you know, and pull any of them out. But once you start putting two or three, you know, we mentioned a single parent. What, like we said earlier, a controlling partner who reads all your mail, who doesn't give you access to your mail, who decides on your healthcare, you know, all these things. Well, what we'd like from you now, if you'd be so kind, I mean, we've just said all them things, all them barriers, all them reasons why someone may not do their screening if it's the bowel screening or attend their appointment. What do you think we can do? A lot of big brains in the room. What do you think we can do to reduce those barriers and get people? Ultimately, our whole thing is about getting people screened and getting people into the doctors as early as possible with potential signs and symptoms. That will genuinely save lives, genuinely. So any ideas that you've got there that you could type in the chat box would be fantastic.
So more targeted education and awareness.
Yeah.
More resources in different languages or easy read.
Yeah. And they do quite a lot. There's Macmillan, again, for those of you that don't know, Macmillan are just like the Amazon Prime of cancer information. They're fantastic. We've asked them for resources in the past, and within 48 hours they've got loads of them to us in you know, particular dialects in Chinese and things, and they're absolutely fantastic.
So we've got a question. I was just wondering how people who are homeless and living on the streets rather than in hostels are supported with screening.
They're not. If they're not registered with the GP, they're not. At best, they will get a some kind of community outreach worker that may or may not raise the question with them and talk to them about it. But no, they are, you know, they're not, because unless they think of it themselves, which is highly unlikely, then it would take a community outreach service to help them. But no. Is there something that, well, it would be great. I've just seen that pop up as well. It would be great if we could encourage community outreach workers too, and it may be something that Megan and myself could do and talk to the organisations like St Anne's. But often, you know, people at home are living lifestyles that are so all over the place and things. You know, it would be great if they would register. That would be a step in the right direction, wouldn't it? If they registered with a doctor, a GP, and had a regular link.
So we've also got resources that highlight just how much early detection, early diagnosis can improve cancer outcome. I feel like most people don't realise that cancer isn't a death sentence.
Yeah, and it's really not. That figure I gave earlier about breast cancer, you catch it at stage 1, 99% successful treatment package. Bowel screening is very similar. If we catch these cancers at stage 1, it's just all over our resources for the project. We have early detection saves lives. It's a real strapline for us.
So we've got tackling the many social determinants of health.
Yeah.
Better working together between NHS and social care professionals using different information systems.
Yeah, talking to one another, everyone knowing everything about everyone else as best they can. You know, people are sometimes a little, I know we've got to respect confidentiality, but it's only useful, isn't it, if someone doesn't suffer in the process. The system's not working, is it, if somebody suffers as a result of that? So yeah, organisations talking to one another without a doubt is great, so nobody falls through the cracks. Yeah.
And there needs to be better outreach to the homeless population and presence in places they regularly access, because being registered is not feasible or realistic.
Yeah,
education, and then education around living with and beyond cancer is a big part of that.
Yeah, and people realising that people go on and live healthy, happy lives because they've got it and had timely treatments. and removing that whole stigma of cancer and getting people more educated about how much can be done. The fantastic clinical interventions that happen. You know, we live in Leeds as well, so we've got a fantastic centre there with the Bexley Centre down in the St James's, a whole oncology wing. You know, some of the greatest minds you could wish to meet dealing with cancer. And I used to work on the teenage cancer unit down there, so yeah, I've seen that firsthand.
And then I think sharing information is especially important when people come to Leeds from other areas of the country. I work in social care and often can't get access to their health records.
Yep, absolutely. People be, and this is that whole thing, and it's for a different day, really. The whole discussion around kind of confidentiality around that, and people not sharing information that's really important and vital to somebody's well-being. And that's when the whole confidentiality kind of thing breaks down, because it's not useful, it's not conducive to somebody's well-being and a positive outcome. But that's a debate for the great and the good, not myself. So I think this is over to you, Louise.
That's great, thank you. So yeah, thank you, Darren, for going through all those slides so comprehensively, and thank you all of you for your comments there as well. I think again, fantastic input and really highly relevant comments, and I think some really key themes there as well. I think what came through very strongly, and so some of the comments in the chat was particularly around homelessness. So I mentioned at the beginning that I do lead the cancer prevention and screening uptake steering group. So I will make sure that some of those themes are fed in through that as well, particularly I think around the homelessness. I think in terms of moving on through the next few slides, I think we're going to build on some of your comments there, and we've almost themed it in terms of what can be done to reduce the barriers. I think we've themed it in terms of how we as a system commission services, how we deliver services. So again, Darren will talk a little bit more about the Leeds Cancer Awareness Service and the approach that they take as a provider in the city. And then we'll have a bit of time to talk about the part, I suppose, that we all play in this system, not just as professionals perhaps working in that system, but as individuals and as patients and as citizens, you know, what part we can all play in supporting both ourselves and the people we know or work with, etc., to know more about, I suppose, cancer, signs and symptoms, and the importance of screening. So what I wanted to start by doing in terms of how we commission services, I think I suppose what I really want to emphasize, and again picking up on one of the comments that was made in the chat there about working together better and working as a system, I think that's something we're really strong at in Leeds, and I wanted to talk you through some of that. So we've really got to a point where we've developed a very strong three-pronged system approach to local provision. So we've got various different services at different levels. So we've got community focus, we've got primary care focus, and then we've got primary care network focus as well. So we've got the Leeds Cancer Awareness Service, as you well know from this morning's session. As I say, Darren will pick up some more of the detail, but just as a brief headline, the overarching aim of that service is that it's targeted in deprived Leeds and with those specific communities where cancer outcomes are poorest. And it very much takes that community approach to raising awareness and getting people into screening. But I won't say too much on that. I don't want to steal your thunder, Darren, on that. So I'll move on to the primary care cancer screening champion. So obviously these are based in primary care. And it's a member of the practice staff team. It could be a healthcare assistant, a member of the reception team, it could be anybody in that practice who has protected time to go through their list of people, we call them DNAs or DNRs, people that have been contacted and they've received an invite for screening, but they haven't taken up that invite. Their focus is specifically, they started with a focus on bowel. That's been broadened to cover cervical, and we're looking at how they bring in more around breast into that role. Now, again, in terms of addressing health inequalities, the funding for that project is which comes from the clinical commissioning group, or has done for a number of years. It's targeted into the 45 most deprived practices, again with the aim of narrowing that gap between deprived and non-deprived in relation to screening uptake. The champion will, as I say, go through the lists they receive of people that haven't attended, and they basically contact those patients, be it by telephone, by letter, by text, with the aim of basically understanding what the barriers are and removing those barriers, taking a real sort of motivational interviewing approach, and a really supportive and encouraging approach, and really understanding what those barriers might be in a non-judgmental way. And then we've got the CancerWise Leeds programme, which has been commissioned by Yorkshire Cancer Research. We've led that in public health, but again, it's a real partnership approach with colleagues across the system in Leeds, and it's delivered through the Leeds GP Confederation. So it does, as I say, take that more primary care network approach, so that's groups of practices working together, and each of the 19 primary care networks in Leeds have access through this project to a cancer screening and awareness coordinator. So they, as I say, they cover all of the PCNs in Leeds, and they again share that ambition as the other two services or programmes that I've just mentioned have as well. And that shared ambition is to accelerate screening uptake and to raise awareness locally. So as I say, it's that real strong partnership approach across the city. What I haven't included in the slide, those are our three sort of key programmes and services. What we also have outside of that is a couple of task groups that focus specifically on two of the health inequalities groups that we've mentioned. So we established them about a year ago now, and again, one focuses on cancer and learning disabilities, and one focuses on cancer and culturally diverse communities, or BAME communities. So again, the aim is to bring partners in the system together around the table to look at what the issues are, where the gaps are, and what we can do as partners in the city to work together to unplug some of those barriers or to develop activity. I suppose what we're doing is really pooling our resources to work together to develop work that will support people to uptake their screening. So, for example, within the Learning Disabilities Task Group, we're really looking at what reasonable adjustments can be made to support people to access their screening. Darren's mentioned some, you know, how traumatic it can be for people going for screening. And if you're somebody with a learning disability and you've never been for screening before, you don't understand the process, the time hasn't been taken to describe that process to you, it can be very intimidating, quite traumatic. And so our work through that group is about making reasonable adjustments. An example I could use of one recently was somebody with a learning disability who was due to have breast screening for the first time. They'd never been before. Obviously, we're very nervous, and actually we facilitated a conversation between the breast screening service and the mother and her daughter with the learning disability, and it was a very simple conversation whereby we asked the question, could the mother go with her daughter and have her screening first, so her daughter can observe that and almost desensitize the process and take the fear away. And actually it just took a conversation, and the services are very open to reasonable adjustments, and also acknowledge that you know, a reasonable adjustment for one person might be very different to an adjustment for another person. So it's, I suppose, getting that message out there that services are open to having those conversations, because people don't always know that. And that did lead to that young lady having her breast screening. And you know, and we know that when people do go for breast screen for any screening, if they've done it once, they're more likely to go again in the future. So that's the point we want to get to. And again, through the culturally diverse communities group, they're looking at really tailored approaches and acknowledging that when we talk about BAME communities or culturally diverse communities, it's very nuanced. There's so much difference within that, as you know, Darren's touched on, as he's gone through the slides this morning. So there's a whole host of work going on basically within the city to address these inequalities and to increase screening uptake.
So, as we I hope you've not heard too much about us already, because this is really specifically what Megan and myself do, the whole thing that we're set up to do as the Leeds Cancer Awareness Service or project. So we need to identify and we know where those are, those highest areas of needs, and then try and have a community approach to get in there, to get known. And you know, we know communities aren't just geographical communities, but there are certain postcode geographical communities and areas in Leeds that have higher incidences, those of higher deprivation. And then we will try and tailor sessions to suit the needs of that specific community. Like we said earlier, bringing specific resources that are going to suit a particular community. Is it better if we do a formal presentation? Would people prefer it if we go table to table? Whatever it might be. You know, when we've done breeze events, we've had bra pong games where you bounce ping pong balls into bras and get points. Now, of course, that was just to keep the children entertained, because we knew in those areas that there's a lot of grandparents who were taking the children to the breeze events. While parents were at work, they were babysitting. So we could have a chat with the grandparents while the children were playing these little games. We will try anything and everything that we think might work to try and engage with the community. And we'll also, and I'll kind of have a bit of a plug for this towards the end, which we're rapidly approaching. We more than happy to come and deliver things either online or face-to-face for staff teams, so that, you know, once we've been along, instead of it being a little one hit where 2 weeks later the information's sort of fading, if we can train a staff team or a couple of members in a staff team to kind of take the responsibility for doing that cancer work and keeping it at the forefront of people's minds, we love that. Because certainly if we use people with disabilities and additional needs as an example, those staff are the eyes and ears. Those staff are the ones that are seeing those service users or customers every day. So, you know, one of the generic signs and symptoms that could potentially be cancer or certainly needs checking out is weight loss. Well, if you're seeing somebody every day and they look like they're getting thinner and they're not trying, they're not eating differently, they're not exercising more, nothing's changed, yet they've lost half a stone or more, then that needs flagging up. But somebody with those, you know, limited comprehension skills surely won't know to do that or worry about that. So it's staff. Also, we'll say to people, if they're helping people get dressed, we've worked with organisations like Home Farm Trusts who go in and help people within their homes. And it's worked. We've trained staff. They've gone out. One staff member helping a lady get dressed one morning noticed there was a change in one of her breasts because of the training we'd delivered, triggered the whole thing to get that checked out. And sure enough, they picked up on an early cancer that was developing. So I think it was a stage 1. So brilliant. That is exactly how we want things to work. You know, how lovely for us as an organisation to know that this woman who wouldn't have picked up on it herself got picked up on because of the work that we're doing. So if any of you would like us to come along and deliver anything to any staff teams or groups anywhere at all, we often joke that we would turn up to a fridge opening. We will go anywhere and everywhere, won't we, Megan? And that we might be valued there. And we know that it's an emotive topic, so when we're out and about, which I hope today you feel that it's been reasonably light, because it's, you know, we talk about bowel cancer and anal polyps on a daily basis for a living. You have to keep it light. Our project's a positive thing. We are trying to stop people experience some of the, the more harrowing aspects of late stage and advanced cancers. And there's no denying that it can be truly horrendous for some people, in later stages, and some cancers can be incurable. But if we get in early and we can encourage people to go, and if Megan and me can turn up and be a little friendly and engaging and take that fear and stigma and worry, and even sometimes get people having a little laugh while we're doing the talks, absolutely for the greater good we will be doing that. And we kind of pride ourselves on that upbeat way of going on, don't we, Megan? Because come on, how could you do the job more than a few years if you didn't, and we'll always make a point of being respectful and sensitive of the fact, especially when we talk to rooms full of older people, there will be nobody in that room on some level that hasn't been touched by cancer, be it a personal experience, a family member, a friend, it's out there. And we do have quite an extensive, Megan absolutely does this really. I'm a little bit of a Luddite. I need to pull my finger out on all things social media. But Megan's just been fantastic, especially over COVID. You can imagine we go out and do talks, presentations, and engage with the public for a living, and all that stopped. So we were lucky that we kind of hit the ground running, and we've got really quite a solid, extensive online presence. An example of that, we put out the Know Your Lemons. If anyone's ever seen that, the Know Your Lemons image, which is just basically lemons in an egg box showing different types of potential breast cancer symptom. And we put that out. I think we had that viewed just over 15,000 times, wasn't it, Megan? Which we were over the moon about, because COVID didn't clip us wings in that respect. And that's a little bit what we look like when we're out and about, but you can probably imagine. So the Megan in the middle there, just engaging the public in Kirkgate Market, because that tends to be a good demographic area for us. But also going out and doing talks for special interest groups. The bottom picture there with the multicoloured chairs was a recent domino competition and information session we did at the BAME Hub up in Chapeltown as part of an ongoing specific prostate cancer campaign aimed at Caribbean and African men, because they're twice as likely to develop prostate cancer in their lifetimes. 1 in 8 for white men, 1 in 4 for black men and people with a prostate. So yeah, that's kind of what we look like when we're out and about. And someone mentioned earlier about the behind the headlines here. These are just really good places to go for your information. If you could give the Daily Mail a swerve, you'd be doing yourself a favour, really. But all of these are great. Some of these are obviously specific. Prostate Cancer UK does exactly what it says on the tin. They've been fantastic as well, haven't they, Megan, over the years, working with them. Macmillan for all your resources, but just a general go-to. We've popped his own little email address in there as well, or rather web address, leedscancer.com. And we're really pleased with his website. It's really grown, hasn't it, Megan? And by the way, if any of you would ever want to do a guest blog on there, if you've had an experience of screening that you were pleased with or not so pleased, or a cancer worry, anything at all that you think, all you'd have to do is just email it as, standard Word document, and we'll rinse it through WordPress and get it all blog ready. And then we would show it you, obviously, before we put that out. But yeah, we would really appreciate that. Any additional content from people apart from Megan and myself is greatly appreciated. So kind of drawing to a close. We'll have some questions in a minute, but the key messages that we wanted to get across today, going back to those aims, are certainly the key messages that our project, Leeds Cancer Awareness, put out. It's okay to talk about cancer. It has to be. We have to be ask people, be opportunistic. If you're having a little chat with somebody and you just, do you go for your cervical, have you had your cervical, or find out a little bit, raise it. You'll be surprised some people don't. And if you can just help them to overcome maybe a little barrier, did you know you could take a friend? That type of information. If you wanted to come to any of our ongoing training sessions as well, which cover a lot more of that in depth, you'd be more than welcome. So yeah, we need people talking about it like we are with mental health, and we need to get rid of this kind of stigma that's attached to it, because people are losing lives because of that. hopefully you'll feel comfortable raising awareness, and we're all about trying to work together. Megan and myself don't have a caseload. You know, we don't have access to groups unless we go out and talk to members of the public. We are reliant on, you know, other project coordinators and group facilitators to allow us in to their groups. So anybody that's in a position where you could do that, would absolutely love that. Yeah, and we just have to change the whole perception of it. Like we said, cancer's not cruel. It doesn't think. It can seem like that sometimes, you know, when we see, it's very emotive, very evocative, isn't it? We see an image of a, you know, a child on a, say, you know, Cancer Research UK advertisement, little child in a onesie with a, you know, a bald head due to chemo and clutching a chemo stand and things. But it's just a condition that can occur that we can help to reduce if we have lifestyle changes, and we have to get over this myth and superstition about it because it's not helping. And yet one of our overarching messages is, if something doesn't feel right, speak to your GP. Whenever we're out and about, we encourage people to kind of go in, you know, be a bit precious about yourself. You know, it's far better to be a bit precious and find out something's, you know, a little cyst or whatever it might be, than to be too gun-ho and bat it off and, oh, it'll be fine, and then find out later on that it's not. And that whole early detection saves lives thing, we just push and push and push that, because it does. All the evidence stacks up, you know, that if we get in early, there's lots. People will often say to Megan and myself, you know, oh, well, that they've already got a cure for cancer, but they're just not letting people, you know, have it as if there's some pill. You know, they don't realize there's over 200 different, they do after talking to us, but at first they don't realize there's over 200 different types of cancer. And for some of those cancers, they very nearly do have what you'd call a cure for it. You know, the 99% successful breast cancer treatment, if we catch it early enough, you know. But people imagine that somehow they're holding it back. They're holding this cure back because they're making so much money out of it. But hey, misinformation's just, fake news is out and about. So, shameless plug. Couldn't leave without a shameless plug. We're just hoping that some of you are sat there thinking, how do I volunteer with these guys and give up a tiny bit of my time to do some good, do even more good than you're doing already? And one of the ways we ask is this digital ambassador role that we have. And it literally, if you use Facebook, it literally is just sharing a post. Megan tends to put one out 3 times a week, and you just click on share. That's it. That's all we ask. Because that's how we're going to get over this. That's how we're going to get it out there. That's how we're going to permeate into people's minds. You might click, you might, you know, post Megan's post, and one of your friends who got their letter 3 weeks ago, it's just that little reminder. Oh God, yeah, there's that thing. Oh, I got my letter. Oh, I'll make the call and I'll phone up. You know, we're not just suddenly going to crush these numbers out of the blue. We're gonna keep working at it. We're just slowly, a bit like reducing smoking. You know, when you look at how the figures have come down for that, if we just keep going at it, there's that saying, isn't there? How do you eat an elephant? Well, it's one forkful at a time, isn't it? And if we just keep going at it, we'll eventually get there. But we do very much rely on other people to share that message. It can't just be Megan and myself running around with a megaphone in Leeds Market, just frightening little kids. So please, if you can, that would be great. But if you can't, I get that as well, you know. And I think that is, apart from this final slide.
Yeah, so it's just pulls everything together basically, just to let you know that a link of today's slides will be sent to you, which Megan has already clarified in the chat. As I mentioned at the beginning, we've also been recording today, so there's just a link to where that will be. There'll be an electronic evaluation survey for today's session, which will be emailed to you. So we'd really appreciate your time in completing that if you can. And yeah, just links to further resources at the Public Health Resource Centre, and links on information that they hold around COVID-19 as well. So again, that just summarizes everything for you there. I just, before we do finish today's session, I'm just conscious that there may be people that have any questions. If you want to, I mentioned at the beginning, if there's anything you want to stay on that you don't want recorded, feel free to do so. But we'll just pause now to see whether anyone's got any specific questions they do want to raise at this point.
So we do have a question in the chat box. Is there anything known about whether there are specific age groups within the target groups who do not take up on screening offers?
Yeah, that's a really good question. And if you remember when I mentioned the CancerWise Leeds programme, just using this as an example, but one of the remits of the role of those coordinators is to really try and understand local level data and get down to a really sort of very, very local level to understand, you know, what the issues are for local communities. And in terms of age groups, that's something that we have discovered through this project. We did know from the data anyway, that screening uptake for cervical screening is lower among younger age cohorts than the older age cohorts. So some of the CancerWise Leeds coordinators did some work in a specific area in Leeds, and I think you may have worked with them on that, didn't you, to really sort of get that local level insight around what it is that's preventing people of that sort of younger age cohort coming forward for cervical screening. And as it turned out in that area, it was something as simple as the screening appointments are offered during the working week, 9 to 5 sort of appointments, and it was all working age women. And taking that insight on board, that particular primary care network acknowledged that. And developed a screening hub between the practices that runs on a Saturday morning, which has enabled those women that couldn't come forward for screening to be able to do so. And I think that's the aim of sort of many of our approaches, is testing models to see whether they work. And because of the success of that hub model, that's now been rolled out to other PCNs across Leeds. So hopefully that might be a way of addressing why those younger, you know, younger women that aren't coming forward for screening, it just increases that accessibility opportunity for them. So is that it for questions, do we think? Yeah.
There's no more in the chat box and I can't see any hands up or anything.
Right. Brilliant. Well, thank you so much, Darren and Megan, for today, and also for everybody that's been on the call today, for all your input. Obviously, we have captured all of that, and as I mentioned earlier, we will be feeding those relevant themes in where it sits appropriately in the city. So thank you so much for getting involved today, because obviously that's what we want to see. We hope you found it useful. Thank you.
Yeah, totally. Thanks for coming along. Really appreciate it.